Good afternoon, everyone. Hi, friends and my senior colleagues. It's a great pleasure to be with you again. This is the first of its kind Times of Orthopedic webinar that we are having with you all, which has been brought to all of us, courtesy Mayor Organics, and with the product that they have, Jointace Trio, which is going to be launched soon. And we are going to have interactive session. Me, along with my colleague, Dr. Dilip Shah, are very happy to be with you today. We are going to be discussing a complex and at the same time a simple problem of osteoarthritis, which is day-to-day problem in our orthopedic life. We have been practicing for more than 40 years and we see osteoarthritis practically in each and every joint. But today we are going to be discussing mainly osteoarthritis of knee joint, and which is a common complaint of patients. And we are going to be discussing the pathophysiology, the pathoanatomy, and the pharmacokinetics at the same time, different modalities of surgical management, if at all required. So, can we have the slides, please? So as I said, osteoarthritis is extremely common, which is common complaint of all the patients that come to the outpatient department of any orthopedic surgeon. And we are going to be discussing current treatment options and probably future prospects in this problem. As we know, osteoarthritis is the second most frequent joint disease with prevalence rate of almost 22% to 39% in India. Up to 45% of women over 65 years having symptoms and up to 70% showing radiological evidence of osteoarthritis, often impacting the mobility of joints. Osteoarthritis was estimated to be the 10th leading cause of non-fatal burden, and that is what we can see now. And especially nowadays, in this pandemic, it is important that we have to keep the mobility of the joints well, and that will help us to mobilize not only ourselves, but at the same time increase the flexibility of us. So what are the risk factors of osteoarthritis? Besides having a genetically predisposing factors, we also have some congenital factors. Age, as I said, more than 60 years, we see these problems very often, and it is also predisposed in the female sex. There are some infectious factors. The obesity is one of the very important factors. The BMI above 30 is likely to give rise to osteoarthritis much early. The joint overuse, especially in athletes, those who are high impactors, running, jumping, etc., those sports, and even sometimes contact sports can give rise to this problem. So these can give rise to joint trauma. Certain surgical interventions and other systemic factors also give rise to altered joint homeostasis. That is interrelated with chronic inflammation, loss of function, and joint remodeling and disorders. So that gives rise to reduction of quality of life. Pain is an important factor which patients complain of, along with joint destruction, the joint instability in certain severe cases, the muscle weakness, which is very important factor that we need to look into, and muscle atrophy. We call that sometimes sarcopenia, which needs to be addressed with the medication and with certain exercises. So let's come to osteoarthritis pathogenesis. There is a high joint loads which goes on to give bone remodeling and modeling with a disruption of cartilage collagen network, which leads to access by chondrolyte enzymes. And these are very important because these enzymes can give rise to loss of aggregans, which are extremely important because if it is not there, the aggregans, then it progresses to cartilage loss. So this is a flow chart of having inflammation, increasing densification. We can also have secondary synovial thickening and loss of B cells. So ultimately it gives rise to loss of enzyme inhibition, and finally the cartilage damage leads to osteoarthritis. And this is a very important flow chart which is self-instructive. So again, involvement of the synovium in osteoarthritis pathophysiology is very important. We see the cartilage damage on the left side, which gives rise to cartilage particles in the synovium, which gives rise to inflammation. And this inflammation gives rise to pro-inflammatory mediators, which are produced. That gives rise to, again, some kind of inflammation in synovium. So this is a vicious cycle which gives the inflammation and again synovial thickening. That gives rise to having the IL-12 and another beta cells, which gives rise to T cells and collagen degradation. And this collagen degradation, in short, can give rise to cartilage damage again. And we can have sclerosis of the subchondral bone due to all this. So this degradation and these degradation products are extremely important in having this progression of the disease. And that must be remembered. So when we are talking about the management of osteoarthritis, it's a pyramid which everybody knows about. There are certain non-pharmacological and basic exercises, education of how to manage this. Prevention of injuries are extremely important, and weight loss and orthotic devices also important. In the exercises, these are actually non-loading exercises or stretching exercises, which will give strain to the muscles, especially for the knee. The quadriceps strengthening, the hamstring strengthening, and also calf strengthening are extremely important. So as for the spine, which we call spondylosis, the osteoarthritis is called as spondylosis, in which paraspinal muscle strengthening are extremely important. In case if the pain continues to go, we can start by giving topical NSAIDs or sometimes capsaicin or lidocaine patches, which are extremely important to alleviate the pain. If that also doesn't help, the oral acetaminophen or NSAIDs or Cisadova, opioids or duloxetine, etc. are used to reduce the pain and help the patient alleviate the anxiety. If that continues to give pain, we have intraarticular corticosteroids and hyaluronic acid. And nowadays we can also give injections of PRP, which are also so-called helpful in certain cases. And of course, finally, we have surgery. So these two modalities, Dr. Dilip Shah will be talking. I'll be talking mainly on the conservative management of osteoarthritis. So we have some pharmacological and procedure recommendations for treatment of knee osteoarthritis. The procedural treatment of knee osteoarthritis, a review of current injectable therapies, which was published in 2020, is an excellent example of some kind of procedures which are recommended in knee arthrosis. And in this, you can see in this chart that there are different associations which are dealing with arthritis. One is from the Canada, one is from American Academy of Orthopedic Surgeons, the Osteoarthritic Research Society International, and American College of Rheumatology. In this, you can see the guidelines that they have come out with and some kind of white papers, and in which they have said recommended, inconclusive, and not recommended evidence of certain products. So in this recommendation, they have said that topical NSAIDs are pretty good. Acetaminophen is also good. Oral NSAIDs are excellent. Duloxetine medication is good. And in extreme cases, opioids could be used. So this is general consensus of these different societies. But at the same time, some kind of herbal medication or some Ayurvedic products or also nutraceuticals, the result may be inconclusive, or we really do not know how it helps or whether it needs to be recommended or not. So there are chondroitin, glucosamine, etc. and the combination of all these have been given. There are certain papers which says that they are recommended, they give good result. But at the same time, we should also realize that even if it is given for longer duration of time, it may not harm the patients. So in this, there is a summary of studies providing overview of the treatment options for knee osteoarthritis. And in this research paper, which was published in BMC Musculoskeletal Disorders, Osteoarthritis, a systemic review of long-term safety implications for osteoarthritis of the knee, we clearly know what are the things which are possible and which could be given. And first and foremost are the exercises. As I told you, there are muscle strengthening exercises, non-loading exercises, stretching are extremely important. Some kind of swimming or even walking in the water, in the shallow water, is recommended, especially for the knee. And these exercises go a long way in helping patients, at least preventing or buy time before the surgery is recommended. So this is a lifestyle change that we need to do. These are the exercises, and there are various different references that we have. The weight reduction is extremely important, and there are different studies starting from 200 patients to almost 600 patients where they have said intervention with exercises and proper diet. And in this diet also, sometimes high protein diet, low carbohydrate diet is like very good. But in case if somebody has gout or problems of high protein diet, they have to be careful about it. So stretching exercises, strengthening exercises is all that is recommended with different studies. And in this, they have studied different VAS and WOMAC score, and they have realized that there are positive responses to all these exercises, and it is very, very helpful, going long way in helping these patients. And then let's come to all these nutraceuticals like glucosamine, chondroitin sulfate, paracetamol, NSAIDs also. And in this also, there are various studies which have given and they have recommended also. These studies have been, the population of this study have been 200 to almost 700. And in this, glucosamine in 1500 milligrams and also paracetamol for 6 to 12 months have been given. They have not really found any major side effects. Some patients were having gastrointestinal side effects, some kind of very rare hepatic, renal, and gastrointestinal side effects have been seen. But of course, overall, they are quite harmless medication, and we could definitely recommend this. So, in this, paracetamol and glucosamine was found to have low risk of harm and beneficial treatment outcomes in more than 12 months. NSAIDs increase the risk of gastrointestinal, renal, and cardiovascular side effects that all of us know, and that has to be judiciously used for short term just to get rid of inflammation and reduce the pain. We could locate no evidence regarding the risk of long term harm like addiction, overdose, and death attributable to opiate treatment in patients with osteoarthritis. So then there are lots of natural products which has some role in osteoarthritis, and these are specially given in different combination. They are at most be called as the nutraceuticals, and we have host of these drugs available to us. I'll just go through quickly with some of the drugs and the chart. In this we have curcumin, which has been quite used extensively. The Boswellia serrata also has been used. Thymoquinone has been used. Genisoposide has been used, and these are so-called adjuvant to the main treatment, and they could be helpful. Same time, we have other drugs which are also in the future pipeline which could be helped. We have astragalin, we have isohematine, and we have resveratrol, and these drugs also can help us. Nutraceuticals could help us in alleviating the pain. So there is underlying a global need for more sustainable natural sources for treatment. The evidence supporting the counterprotective potential of natural products is still building up. However, arriving at that kind of solution requires more clinical research, targeting the implications of long-term treatment, adverse effects, and epigenetic implications. So we have various glucosamine, chondroitin, and similar nutraceuticals that we have, which have so-called help in alleviating the pain and getting these patients up and about, making them to do some kind of exercises and at least postponing the surgical outcome. So thank you very much, and I would be handing over to Dr. Dilip Shah for a main surgical intervention, giving intra-articular injections, PRP, and various different modes of surgical and invasive management of osteoarthritis. Let me now come to the video, which is giving you a certain combination of nutraceuticals, which is extremely helpful. I'll hand over to Mayer Organics, and I'll also hand over for this joint test trial. मेसेज होता त्यात म्यूट करना म्यूट करना Yeah, so since you have seen this video, I think perhaps we probably have a solution to take care of arthritic changes or collagen degradation. We will be able to get some kind of good results with joint test trio. And we have done the clinical study. We have found it to be extremely useful and even in the long term. So, friends, I will hand over to Dr. Dilip Shah for the surgical and invasive management of osteoarthritis. Over to you, Dr. Dilip.
Yeah, you'll have to stop sharing your screen, then I can join.
Yeah.
Hello, good afternoon, everyone, and thank you very much for giving such wonderful explanation about osteoarthritis and the medical management. I am Dr. Dilip Shah, and I'll talk to you about few aspects of osteoarthritis, namely visco supplement, which have been told that I'll talk to you about it. And it's my privilege to introduce visco supplement because I have been using it, and it's an intraarticular injection of hyaluronic acid. It is widely used in symptomatic knee osteoarthritis. Visco supplementation is an effective treatment for OA of the knee and a few other joints like shoulder, also ankle, wrist have been tried on pain function and patient global assessment, and at different post injection periods, but especially at the 5 to 13 weeks post injection period. Now, there are many injections which have been tried, and in that situation, if you want to understand, there can be a combination of pure hyaluronic acid like Hyalgan GF20, or you have hyaluronic acid along with there are some people who used triamcinolone, or they used dexamethasone, or they have used dipomedrol, and also of late there have been more additions like sorbitol. The results have been good, and there are some people who have injected PRP, platelet rich plasma, and even combination of that also is being done. Visco supplement, how does it work actually? Consists of injection of viscoelastic HA into osteoarthritic joints for restoring the rheological properties of the synovial fluid. Need to slow down the progression, and moderate OA need to slow down progression and delay the surgery or postpone the surgery in patients unwilling to undergo surgery or those who are posted later on. So intra-auricular HA, it is chondro protection. It gives you lubrication. It gives you subchondral bone, which is stronger, analgesic effect, anti-inflammatory effect, and proteoglycan and glucosamine glycan synthesis also it improves. And the characteristics of viscosupplementation is extraction of hyaluronan, can be of animal source or bacterial source, cross-linking of hyaluronan to form hyalan if required, to increase molecular weight, residence in time of the joint, and it needs to be sterilized. The hyaluronic acid which is injected goes into the knee joint, and it lubricates, at the same time gives cushioning effect to the tissues like the menisci, the cartilage, tries to each and every cell of the joint where it has been injected, and gives dual effect. There could be combination of intra-articular injections. Combined injections of corticosteroid and hyaluronic acid can safely lead to an increased reduction in pain in the first 2 to 4 weeks post-injection compared HA alone. This is a positive aspect, and when we had a summit of those who have been using hyaluronic acid into the joints, this point came out. So this is a study which has been done, and which is the result of that. And combined intra-articular injection of HA, PRP, and corticosteroid also has been studied. And based on our study, this study is by Sanjay Kumar and Vasudevan, that we conclude that combined intraarticular injections of HA and PRP steroids, they are quite helpful. So PRP injections for knee arthritis, PRP therapy to be very effective at relieving pain and returning patients to the normal lives. And PRP contains different growth factors which regulate key processes involved in the tissue repair. The rationale of topical use of PRP is to stimulate the natural healing cascade and tissue regeneration by supraphysiological release of platelet derived factors directly at the site of treatment. PRP has been successfully used in surgical and OPD in the treatment of muscular and skeletal problems. The need for surgery can also be greatly reduced by treating injured tissues before the damage progresses and the condition is irreversible. Now, what surgical options do we have in management of OA? A summary of surgical option in the management is if you have symptomatic treatment, arthroscopy is being done, but I'll discuss about arthroscopy later on. Joint surface restoring procedures like cartilage, autologous chondrocyte transplantation, autologous osteochondral transplantation, bone microfracture drilling, and aberration arthroplasty. And for joint alignment procedures, like we have osteotomy, proximal tibial osteotomy, distal osteotomy. And for joint replacement, we have unicompartmental UKA and total knee arthroplasty. Osteotomy, high tibial osteotomy. Several types of osteotomies have been described. These include opening wedge, closing wedge, oblique, plain osteotomy, ball and socket of McVeigh type. However, the opening and closed wedge have been popularly used. Of the type of osteotomy, the aims are similar to normalize the mechanical axis and offload the degenerated side. Osteotomy of the proximal tibia has been used for more than a century to correct angular deformity in the setting of rickets, poliomyelitis, and post-traumatic conditions. Jackson is credited for being the first in the English language literature to report performing a proximal, that is, now we call it as high tibial osteotomy, to treat osteotomies of the knee. Jackson's concept was subsequently adopted by Coventry. So we also call it Coventry osteotomy, and Insall, who refined and popularized the lateral closed HTO. Initial experience indicated that HTO was effective in relieving the pain of unicompartmental osteoarthritis. HTO has been temporized by two factors. One, recognition of the procedure's limitations. Two, evolution and clinical success of total knee. So we have been doing it very rampantly in the era of 80s till maybe 1995. But then, because of some of the drawbacks, it went out of picture. But again, with Tomofix and all, it is coming up. It is not an ideal treatment option for patients with significant bicompartmental or tricompartmental osteoarthritis. Results of procedure are progressively deteriorating, so a second surgery of total knee replacement may be difficult, not impossible. How do we use the HTO? Medial compartment osteoarthritis is physiologically young, active patients for whom total knee arthroplasty is imperfect for long-term solution. Because of late we are seeing many young people having osteoarthritis. So if you start doing total knee arthroplasty in young people, I think they don't have any salvage after 20 years. HTO imposes no permanent activity restrictions. Superior results are more likely with contemporary fixation and post-operative management techniques after HTO. Evolving chondral resurfacing techniques are contraindicated in presence of tibiofemoral malalignment, mandate concomitant correction of significant coexistent angular deformity. So combining HTO with chondral resurfacing procedures may provide better results than only doing HTO. Let's see the indications for doing HTO. Patients with varus limb alignment or with valgus limb alignment, adult osteochondritis dissecans, osteonecrosis, posterolateral instability, chondral resurfacing, the ability of the patient to use crutches after the operation and the possession of sufficient muscle strength and motivation to carry out a rehabilitation program. Otherwise, if they don't have this tendency, they will blame you. Good vascular status without serious arterial insufficiency or large varicosities. Now, for varus limb alignment, the most common indication for STO is isolated medial compartment degenerative joint disease, and we go ahead with valgus. If they have too much of valgus, basically seen in rheumatoids, they may be done. And even in osteochondritis dissecans, STO should be considered in physiologically young active adults with osteochondritis dissecans of the medial femoral condyle. It is reported that STO reliably decreases pain and improves function in patients with osteochondritis dissecans. Even in osteonecrosis, it is harmful. And if there is posterolateral instability, then there could be a problem. Isolated soft tissue reconstruction procedures for posterolateral insufficiency are likely to fail in the settings of varus alignment because of the reconstruction is subjected to excessive tension. Hence, performing a valgus producing STO before or in conjunction with the ligamentous reconstruction should be considered when there is varus malalignment. We can do chondral resurfacing along with that, but you should know what are contraindications to high tibial osteotomy. Severe lateral compartment degeneration, significant portion of the lateral meniscus, symptomatic patellofemoral degenerative joints. You can do a kind of pushing the patella forwards, and you can make that effect by bringing the distal fragment little in front. Thereby, you can reduce the patellofemoral arthrosis problems. But if it is too bad, you should not do it. Patient unwilling to accept the anticipated cosmetic appearance of the desired amount of angular correction. And in case of inflammatory arthritis also, more than 20 degrees of correction needed, then you need to do femoral osteotomy. Knee flexion of less than 90 degrees is going to be stiffer than flexion contracture of more than 15 degrees and lateral tibial subluxation more than 1 centimeter. You must be wondering when we can do arthroplasty and when we should do tibial osteotomy. Let's say medial compartment disease is a physiologically young, high demanding individual is ideal scenario for STO. But when you have multi-compartmental disease in a physiologically old, low demand individual is the ideal scenario for total knee arthroplasty. Isolated medial compartmental disease is a physiologically old, low demand individual appropriation for either TKA or UKA. UKA should not be considered for STO. In the physiologically young, high demand and individuals, we have this normal axis 5 to 7 degrees of valgus, and this is the varus deformity. So we bring back to normal methods. We have three methods of doing it. One, closed wedge osteotomy, second, dome osteotomy of 5 degrees of valgus. That will be the base of your triangle, which you will take out if you are doing a closed wedge osteotomy. And similarly for open wedge. And McQuaid's barrel and wall type of osteotomy does not require any wedge to be taken out, but it is little difficult and more challenging, so it is losing its importance. When we do lateral wedge osteotomy, you must realize that you must do it within when you need a base less than 2 centimeters. If it's more than 20 degrees, you can't do it. And then you can fix it with Tomofix. This is the wedge. If it's a strong fixation, there is no need to insert anything over there. And there are some jigs available which gives you exactly how many degrees you want to do the correction. You can also fix it up with Lizarov method. If you do medial wedge osteotomy, which is opening wedge, then you must realize that when you do medial osteotomy, you need to insert if you feel any kind of bone grafts, otherwise do a strong fixation. When you do dome osteotomy, it is less commonly used to be more technically demanding operation. Advantage of intraoperative flexibility, which allows the surgeon to achieve the precise amount of desired angular correction. So you don't take out wedge and you can get as much correction as you desire. If combined with external fixation, the amount of angular correction may be adjusted post-operatively also. That's the advantage of doing an external fixator. In contradiction to lateral closing wedge or medial opening wedge techniques, dome fragment little bit infra osteotomy, there can be Tosh, Schulz, but complications are also there. You must keep in mind there could be patella baja, fracture, non-union, Parolin palsy, compartment syndrome, infection, and thromboembolism. And there are occasions where I have seen people doing osteotomy, which goes into the joint, which is the most dreaded kind of complication. And total knee after doing high tibial osteotomy becomes little difficult, and especially when you have fixed it with something. And the L-shaped scar, previous closing wedge osteotomy, is a big problem, and the surgeon must be aware of proximal tibial deformation caused by STO when planning and executing the proximal tibial section during total knee arthroplasty. So these are some of the complications which are associated with open wedge osteotomy. So non-union, fracture, complications from the implant, generalized complications which are common with everything, wound infection, DVT, vascular injury, compartment syndrome. If you want to prevent vascular injury, you should keep the knee in flexion of almost 40 degrees and put your pillow or folded pillow or a bolster little above the knee so that all the necessary major blood vessels and nerves are way behind and they do not come in the picture. The current concept is that we must use a spacer plate or a tomofix. Open wedge osteotomy also requires that without feeling defect, you can do it if you have a good fixation. So these are some of the fixations after having done high tibial osteotomy. So much about high tibial osteotomy. Now let's go to arthroscopic debridement. In one-time stroke, one of the commonest procedures performed, and RCTs have proved what is the role of arthroscopy if you have loose bodies or intra-articular bodies, not for meniscus tears, if a significant OA. So it says that there is no benefit to arthroscopy compared to physiotherapy and medical treatment. Meniscus tears are common in OA of the knee, and 81% of the surgical patients had debridement of the meniscus rather than joint debridement. And attributing pain to meniscus tear is difficult. 52% had catching, locking, 88% had joint line pain. No difference at 6 months, 30% crossover. Bottom line is try physical therapy first. And it has been proved that arthroscopic debridement for the knee by Cochrane study database is very huge. Arthroscopic debridement has no benefit for indiscriminated OA. So it is going out of vogue. Arthroscopic lavage and debridement is an effective method of treatment of osteoarthritis of knee in patients with grade 1 to 2 osteoarthritis having symptoms of pain and locking due to loose bodies and degenerative meniscus. Please mark my words, is because of the loose bodies and meniscal problems. Now coming to HTO versus unicompartmental knee arthroplasty for medial compartment arthrosis with kissing lesions in relatively young patients. The endpoint is HTO is comparable to UK in terms of clinical outcomes. Thus, the results of this study suggest that HTO might be a good alternative treatment to UK for medial compartmental arthritis accompanied by kissing lesions in relatively young patients. Now, UK, if you want to study well, with improved prosthetic design. See, earlier the designs were not so nice. Now they improved the surgical technique where properties of polyethylene, and recent publications of better long-term results, UK has undergone resurgence. And I had talked about George W. Bush, who had also undergone UKA, and after that it became more popular. The prerequisite for UKA are stable joint, correctable varus deformity, fixed flexion less than 10 degrees, and minimal lateral compartment disease. ACL should be intact, very important. The relative merits of UKA over total knee are shorter surgical time, less blood loss, quicker rehabilitation, and better range of movement. Moreover, the revision of UKA to total knee replacement is reasonable compared to revision of TKR. 90% good, excellent results in terms of pain and function in patients less than 60 years with an average follow of 2 to 6 years and survivorship of 93% at the 11th year. UK can be done by minimally invasive method, very small scars, good range of movement. People have started doing it as an OPD procedure, but there are risks. Please remember, knees without a functional ACL, as I told you and I will reiterate, ACL is very important. If you do not see that, then there are 10 times more chances it will fail. Patients who have more extensive degenerative joint involvement of contralateral and patellofemoral, polyethylene wear and aseptic loosening, and degeneration of the uninvolved compartments, pes incidentus bursitis, and infection. Post-operative outcomes of total knee arthroplasty as compared to uni. Patients with primary medial compartment OA who underwent UK had less post-operative pain, earlier return to work, and higher knee score compared to mesh group who underwent total knee arthroplasty. But coming to total knee replacement, it is sold as the final option. You don't sell total knee arthroplasty, patients should beg for it. Advances in the implant design with better polyethylene wear properties and appropriate patient selection. Reproducible results of 96% have been achieved at 10 years. Timing of knee replacement is still debatable. And Gidwani et al. In a series of patients have reported that good results can be obtained when intervention is carried out at earlier stages of radiographical OA in symptomatic patients. The overall complication rate following primary TKA is 5% in patients, infection around 1.5%, and symptomatic DVT and pulmonary embolism between 1 to 3%. This increases to 26% following revision knee replacement. One of the main risk factors for early revision as per Swedish arthroplasty register is young age. Hence, orthopedic surgeons are often reluctant to offer TKR for young patients. Duffy et al. At minimum follow-up of 10 years reported survivorship of 96% at 10 years, 85% at 15 years. The average at the time of surgery was 56 years, 53 years. So it is commonest underlying diagnosis of TKA is based knee osteoarthritis, other non-traumatic arthritis conditions including rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and AVN. TKA is associated with significant improvement in pain, function, and quality of life of patients. I'll show you few cases. Such ghastly appearance. There is no other solution but to do TKA. See the gross deformities. There is deficient medial condyle of tibia, which is being reconstructed. You can see this, how it has been reconstructed well. And this is the post-op result where it has been reconstructed and you can shift either medialize or lateralize wherever there is no defect as such. Or see this case, severe deformity. But see the function, post total knee arthroplasty. It's really making the patient as well as the doctor very happy. Now, this is a patient, especially I have chosen where a uni was done and on the right side, a constrained knee has been done and the uni has failed. So the uni has been replaced by total knee arthroplasty. But remember, once you do revision in a uni, maybe you will require some stems or some other augmentation or something or the other. So keep it in mind. It has been augmented here and we have put the stem there. After having finished about total knee replacement, we have to look for what are the new frontiers like cartilage transplants. Cartilage regeneration technology has the potential to repair these lesions and prevent their progression to debilitating OA requiring total joint arthroplasty. Treatment options to address comorbidities in patients with cartilage lesions. And we can really improve it. Or cell based therapy of osteoarthritis. The classical definition of OA as a wear and tear, non inflammatory degenerative disease, recently transitioned to an inflammatory disease driven by abnormal innate and adaptive immune response. Accordingly, cell based therapy of OA is nowadays mainly focused to regenerate injured cartilage and at the same time attenuate ongoing inflammation with the affected joint. Autologous chondrocyte implantation. Currently, autologous chondrocyte implantation ACI is the only cellular based therapy approved by US FDA. ACI is based on three-step protocol. First step is isolation of autologous chondrocytes from the cartilage surgically obtained of a known weight bearing area of affected joint. Second step, in vitro expansion of the chondrocytes. And third, implantation of the chondrocyte into the damaged area of the articular cartilage. ACI has limitation. Harvesting of the patient's own cartilage is an invasive procedure. Chondrocytes are not rapid proliferating cells capable of long-term ex vivo cultivation and immunosuppression. When you don't have healthy cartilage, like in gross chondrocytes may undergo undesired micro affect the efficacy of this, enable rapid proliferation, maintenance of differentiation, potential of major histocompatibility complex MHC. Although bone marrow and adipose tissue have been most usually used as sources for osteum and synovium. The International Society for Cellular Therapy flasks more than 95% of the cell population must express epithelial cells and thrombocytes. The cell must be able to differentiate into adipocytes, osteoblasts, and chondrocytes understand under the standard in vitro differentiation conditions. So how do we get it? Strategy of cartilage engineering based on mesenchymal stem cell for adipose tissue. So adipose tissue is taken and then we have the MSCS based on this. Secondary osteoarthritis in animals like mice, rats, pigs, dogs, horses, and donkeys was included mechanically by surgical induced cartilage injury, ACL ligament transaction. or chemically by intraarticular injections of collagenase or steroids, and MSc has successfully attenuated clinical and radiological symptoms and signs of osteoarthritis in experimental animals by promoting cartilage regeneration and by attenuating the joint inflammation. So, this is MCS based suppression of immune response in OA, and mesenchymal stem cell based therapy of osteoarthritis has shown it has got future perspectives, and these are some of the clinical studies which have shown that it is the future. So when we discuss about the future, but there are some challenges which need to be addressed. MSc isolation yield very heterogeneous cell population, so may account for variability in cell growth and chondrogenic potency of that. Biological markers for identification and possible isolation of potent cells are needed. More standard such as geomic stability tests are needed. Need to develop efficient serum-free, xeno-free media and downstream processing such as cell harvesting and removal of microcarriers from the cell product still need to be explored. So we have many other newer things coming up, and there are many myths and facts also if you want to know. Is osteoarthritis just a joint wear and tear process? No. Now it has been said that osteoarthritis is commonly typified by structural cartilage changes. However, there are also changes in the muscles, bone, and synovial tissue at the joint. Hence, it may be called not only as a disease, but it's a syndrome by itself. The worse the imaging looks, the worse is the joint. No, you go by the clinical function of the patient. And if you think osteoarthritis is non-inflammatory arthritis, no, it's also not true. Osteoarthritis was traditionally considered to be non-inflammatory, so we all insisted we call it as arthrosis. But arthritis is all right because it has been proved that there are inflammatory processes also happening, and the synovial tissue inflammation is believed to be one of the key intraarticular processes that contributes to nociceptors and the subsequent pain experience with the inflammatory changes leading to intraarticular swelling. Moreover, extraarticular structures can also become inflamed and contribute to the generation of nociceptive input. Conservative treatments are ineffective and only designed to delay. No, we also should believe that, like Dr. Ram Prabhu said, that we must go for reduction in weight and exercises is most important. Change in the lifestyle also is important. Joint replacement surgery is inevitable. No, don't go by that belief. Total joint replacement continues to be a valid treatment option for people with advanced hip and knee osteoarthritis, but total joint replacement surgery is not appropriate for everyone with OA. Disease progression differs from person to person, and many people may never reach the point where total joint replacement surgery is appropriate and necessary. So, in summary, I want to say that OA is a chronic disease with no cure or modifying treatments. Need good plain X-rays to determine the disease severity. MRI is generally not warranted as a part of OA. Arthroscopic treatment of knee OA is rare. Use published clinical practice guidelines (CPG) for non-operative treatments. In summary, total joint arthroplasty is a powerful tool operation with predictable results in most patients. Exhaust all reasonable non-operative treatments. The patient should be in shape for good surgery and in good shape. No smoking, weight loss, drug and alcohol free medical comorbidities should be made stable, able to participate in the rehab. Stable psychiatric and social situation, motivated, and complications and poor outcomes can be disastrous. So bear in mind. So I want to say that life is movement, movement is life, and we must maintain movements and life. We can move during this COVID stay at home phase, but then we must give the patient back his movements. And this is one very nice thing that can postures cause problems. Regular walks for long distance over rough ground and frequently lifting of heavy objects, especially jogging on hard tracks. If you want to do jogging, it should be on jogger's track. High stressful life, high obesity and less movement bad sitting and standing habits like squatting and sit cross-legged for a long time can be detrimental. I thank you very much, and then I'll stop sharing my screen so that people who are coordinating can take over.
Hello, sir. As there was some issue while playing the video, so I will be replaying the video as there was no audio heard earlier.
Yeah, I
So,
have sent that message. Please use, and whoever is playing that video should switch off his visual video. That means his face should not be seen. Then it will not take a lot of bytes and your video will play well. Okay?
Anti-inflammatory with virtually no side effects. Oflapin is a large branching tree found in India, and the resin from the tree contains medicinal ingredients known as boswellic acids, and they are powerful natural anti-inflammatories. The way that they work is that they block a particular enzyme called the 5-lipoxygenase.
Oflapin is highly effective in providing arthritic pain relief.
Oflapin, virtually no side effects, no drug interactions.
Collagens are the most abundant family of proteins in the extracellular matrix of connective tissues. They perform a variety of important biological functions, the most known of which is its structural role. According to the three-dimensional shape, 26 different types of collagen have been described. Type 2 collagen is the main structural protein in the cartilage and provides tensile strength and toughness to the tissue. Some joint disorders involving inflammation and cartilage erosion are caused by an immune response against endogenous type 2 collagen. NUC2 is a natural product supplying native type 2 collagen. The strictly controlled extraction and manufacturing process of NUC2 type 2 collagen to maintain its native form, the biologically active structure of the collagen molecule, thanks to preserving its native form, works through an immune-mediated mechanism of action called oral tolerance. It consists of a diminished immune response to a previously administered substance. When orally taken, NUC2 passes through the stomach without being denatured and reaches the Peyer's patches in the small intestine. Peyer's patches are lymphoid nodules responsible for immune surveillance of the intestine lumen. They activate or deactivate the immune response against foreign substances. In the Peyer's patch, NUC2 is recognized as native type 2 collagen by the immune cells and binds to them. It is important to highlight it is not absorbed, and it turns off the immune response against endogenous type 2 collagen, just linking to the immune cells. After that, immune suppressor cells go out of the Peyer's patch and reach the joint, where they stop collagen destruction. Thanks to this specific mechanism of action, a small dose of NUC2 is able to reduce joint inflammation and cartilage degradation. Therefore, it relieves joint pain, improves joint function, and helps stay active.
Hyaluronic acid is an essential substance generated by our bodies for correct joint function. It works as a lubricant, reducing friction and facilitating motion. Nevertheless, the quantity and quality of the hyaluronic acid generated by the body decreases with age and with the presence of joint problems due to overuse or injury. That is why we have created Mobili, a natural ingredient rich in hyaluronic acid and other components components, such as collagen and polysaccharides, which increase its effect. Its efficacy has been tested in more than 10 different scientific and clinical studies, which show that Mobility multiplies the body's natural production of hyaluronic acid in the joints by 10. The effect of Mobility is more potent than that of other hyaluronic acids, thanks to the combined action of all of its components. In addition to lubricating the joints and improving mobility, this product also reinforces the muscles. Take a product containing Mobility for at least 2 months and enjoy your mobility, agility, and strength. Mobility. Enjoy moving.
Yeah, so we've had an excellent surgical intervention lecture by Dr. Dilip Shah. There are certain questions that we would like to answer. If you can hear me, Dr. Ram Pithe has asked that is osteoarthritis preventable? The role of diacerin and glucosamine in osteoarthritis, and can this combination be used in diabetes? So there are 3 questions. The first one is, can osteoarthritis be preventable? Just as Dr. Dilip Shah and myself has emphasized, there are diet control, obesity control, and at the same time exercises, which can postpone the osteoarthritis incidence, and we can definitely get it controlled or getting it postponed for treatment. There are so many people at the age of 75, 80, they also do not suffer from any osteoarthritis or arthritic changes or arthritic problems. So this is because of the constant exercises that they have done in the past, and they have maintained their BMI very well. And this is very important. About diabetes, it is important question that diabetes needs to be controlled and kept in control all the time. At the same time, any kind of medication should not be given for a longer period of time, whether it is nutraceutical or anyone. The nutraceuticals are relatively safer drugs, but they should not be given for a longer period of time. The combination of diacerin and glucosamine is also advocated in some of the combinations that we get. Both these are, of course, act like a diacerin and glucosamine, they act as an adjuvant to the main therapy. Dr. Gopal Sharma from Nepal is asking, I'm using duloxetine in my patients for long time in OA. Do we need extra precautions for using long time duloxetine? Thank you. There are no scientific evidence of duloxetine to be used for longer period of time and what are the side effects. But at the same time, this has a potential side effects, and we have to be extremely careful in using this for longer period of time, especially if those patients who are elderly and they have comorbid problems. So we have to be extremely careful. How much glucosamine is effective for treatment of OA? 1500 milligram is a dose which is recommended for osteoarthritis treatment by glucosamine. There are various combinations which give also 750 and 500 milligram, but that is not so effective in controlling the mobility or managing the mobility and flexibility of these patients. We have recently come across ingredient Mobili, which is unique combination of hyaluronic acid along with collagen peptides and polysaccharides. This we have used this clinically in many patients in the last 1 year before this medication is actually launched, and we have found it to be extremely useful. The time will only tell how much useful over a period of long period of time when we use it. There is one more question by Dr. Ravindran that there are three major areas that we must focus on to provide comprehensive treatment in OA. One is providing arthritic pain relief, providing joint protection, and improving the mobility of the patient. And all three are extremely important. We must reduce the pain. Unless we reduce the pain, there is no possibility of mobilizing that joint, and the flexibility can be obstructed. And that's why we have to reduce pain by controlling the pain in various different ways that I have told you. The joint needs to be protected in the beginning if it is swollen, inflamed, and that is also very important before you actually start the mobility. The improving of the mobility becomes the third part or third stage when you have actually controlled the inflammation, and that is important. There is one more question to Dr. Dilip Shah. Do you prefer simultaneous TKR or one by one stage procedure? So, Dr. Dilip Shah, please.
Yeah, it's a very important and boiling question. In younger patients who are medically fit to undergo both the knee replacements, but then you should always counsel the patient by saying that if the anesthetist feels at the end of first joint replacement that we cannot go ahead with another one, you can defer it by 3 days to 7 days. In court of law, one doctor was sued for doing bilateral total knee who had lots of complication, and he was considered to be guilty. So you have to put medical legal aspect also in your mind, that it's very important that you finish off the surgery in 2 stages if you are scared of this kind of medical legal litigations which can be against you. But in younger people, it saves lot of energy, money, and the hospital stay for the patient if you can do both the knees together. If you are an expert, I think you can do it very well, but make sure that you use tourniquet only at the time of cementing. Please remember, don't use continuous tourniquets, and if necessary, you have to employ all the possibilities of prevention of DVT. These are the 2 things which will come in the way. So be very careful, one, from medical legal aspect, if you're doing bilateral together, and second, DVT is the detrimental. And I must compliment Dr. Ravindran that whatever has been spoken today by Dr. Ram Prabhu and me, he has really written in 2 sentences. I compliment you, Dr. Ravindran. Yes, Dr. Ram Prabhu.
Yeah, so there is a question by Dr. Sudhakar, role of heredity in developing osteoarthritis. See, there is a definite correlation of genetic predisposition, and we have seen that in families and in uncles also having this osteoarthritis. There is a greater chances of next generation having osteoarthritis at a younger age, and this definitely is genetically proved. There is one other question that please confirm that this medication can be given to the post-angioplasty patient safely by Dr. Jay Prakash Kesharwani. Most of these nutraceuticals which you have said, and including this Mobili and Jointis Trio, can be safely given in patients who have had their angioplasty, and even if they are taking any antihypertensives or some cardioprotective drugs. So I don't think there is any reason for being anxious, or you should not be. You should take care, of course, and you have to take this medication properly. How to differentiate between seronegative and seropositive arthritis clinically in limited facility? Yeah, so this is a very good question, because these are the questions which will be asked by maybe tier 3 cities and some of the remote areas where there are no possibilities of pathology testing, etc. Clinically, by joint involvement, or if it is a polyarthritic problem, we will be able to make out that this is something like a rheumatoid or rheumatic problems. Polyarticular problems, you have to be extremely careful. It is also possible that you can have primary osteoarthritis in various different joints, but at the same time, it is of course the history which is extremely important, the clinical examination of finding out the different joints, if they are swollen in stages, or whether there are peripheral joints which are affected, or if there are central joints which are affected. These are important to pointers to find out whether there is a serial positive. Of course, the final confirmation could be done by blood hematological examination. Okay, Dr. Gautam has asked Dr. Dilip for tourniquet and TKR. You can please answer.
What is the question? Because I have not got
Okay,
this.
use of tourniquet in TKR.
Mukesh Gupta has asked, what is the role of hydroxy?
No, I'll tell you. Dr. Gautam Gaikwad has asked use of tourniquet in TKR
Use tourniquet in TKR
and drain in TKR.
It's a wonderful question because it's like Shakespeare's question, to be or not to be. If you are tuned to using tourniquet, tell me one reason why you are using tourniquet from very beginning. Are you scared of bleeding? There is hardly any bleeding. Try once, I tell you. Do cementing under tourniquet, I tell you, and you will really thank me for this. There is no excruciating bleeding. In fact, what happens is, if you have used tourniquet from very beginning and when you release tourniquet, there will be fountain of blood and you will not be able to catch the bleeders. In fact, if you do it without tourniquet till you reach a level where you want to cementing technique and then use the tourniquet, you have caught most of the bleeders. And then when you release tourniquet, there is not going to be much of bleeding. One. Secondly, there are two schools of thought about using drains. Because drains, in one way, it really takes out the blood which is not wanted inside. Secondly, it becomes a source of infection after 48 hours. So use judiciously. If you have achieved good hemostasis, you don't need the drain. But even then, to be on safe side, you are from the school of thought that you must take out the drain, put the drain, then see how much it is drained on the first day. If it is drained quite a lot, keep it for 48 hours, but not beyond 48 hours. I hope this answers both the questions, and they are wonderful questions, so important for a joint replacement surgeon.
There's a question from Dr. Mukesh Gupta about using HCQS. Okay, HCQS is not the primary or the first drug of choice in managing osteoarthritis, but it can be also given in combination with other drugs in rheumatoid especially. It is found to be quite effective, but it has to be used judiciously. What about you, Dr. Dilip? Have you been?
Yeah, HCQS, actually, in our studies also, we were using mainly in rheumatoid arthritis because it's a disease-modifying agent and is not used singularly. And we used to get one side effect of that was mainly retinopathy if you use more than 400 milligrams per day. But then later on, the arrhythmias also came into picture, especially in today's time when we are using for COVID patients also. Patients do not die because of getting COVID infection, but they used to die because of arrhythmias. So the potential cases of arrhythmias, you have to get their ECGs done from time to time and keep a watch whether they are developing arrhythmia, and do not go for more than 200 milligrams if you want to be on safe side. So that is so much for hydroxychloroquine.
Okay, so Dr. Gopal Mishra has asked you, Dr. Dilip, is there any score to find out the gradation of OA on which you decide the surgery or surgical management?
Wow, that's a fantastic question. And in my presentation, I said that if the X-ray looks ghastly, but when you see the patient, he has got good range of movement, then he is not an ideal candidate to undergo total knee replacement. And there have been some examples when I have insisted for total knee arthroplasty and patients have not agreed. Then I have employed the tactic of buying the time and postponing the surgery. So one, you should total joint arthroplasty. Let the patient beg for it is the best for. Sorry, the internet is getting unstable. Can you hear me well? Yeah, it's stable now. Is the best indication for doing surgery. And if you want to see those situations, if you don't mind, can I share my screen and show such cases where patients were not willing and we had to postpone surgery? Dr. Ramprabhu, do you agree?
Yeah, sure, definitely. In fact, radiological correlation and clinical is very different. So you don't go on X-rays to decide the severity of the disease. It's very important that
Okay, I am
clinically
sharing my.
correlate.
Whenever you say, I will speak.
Okay.
Dr. Ram Prabhu, you please
And the
complete.
severity of the disease depends on the mobility or the range of motion, the pain, the functional disability that patient has, and at the same time the radiological. So we have to correlate all that to decide actually whether it's a grade 1, 2, 3, 4. And sometimes grade 4 patients also, as Dr. Dilip said, that they may not have any symptoms and they'll be functionally pretty well. At the same time, grade 2 patients also will have severe pain if they have some meniscal problem. We have to be a little careful about internal derangement of the knee when we are actually thinking about osteoarthritis. Dilip, go ahead.
Yeah, I am trying to corroborate where I felt that the patient needs joint replacement, but patient for some reason or the other didn't agree to that idea. So I'm talking about case one where I had done high tibial osteotomy 10 years before I saw that patient in 2000. So in 1990, I had done high tibial osteotomy, had severe osteoarthritis of both the knees. In 2000, I saw the patient. She is the patient, and you can see the scar. I normally used to do high tibial osteotomy by a transverse incision, and I am of the opinion whether you do by transverse or vertical incision, after 5 years, wound healing is never a problem whether you take a vertical or a transverse incision. For high tibial osteotomy, my criteria used to be like if you want to do correction of 10 degrees, then you just make shell out of fibula so that when you close the wedge, fibula will crack absolutely fine. But if it's more than 15 to 20 degrees, then you have to give distal attachment also to the proximal part of the fibula. So much for high tibial osteotomy. Now, this is the picture of that patient after high tibial osteotomy. What do you feel? She'll
Very good.
definitely require total knee replacement.
Possibly if she is functionally disabled and her
She is
range of motion.
disabled, and she is owner of a boutique in Bangalore, and by the name and style Simran, she used to work. Till today she is working, but these are the pictures of both the knees. Now looking at these x-rays, you feel that she'll need surgery, but she refused that she has some wedding and this and that. That's the usual thing. So what would you recommend? Intraarticular injections of visco supplements, nutraceuticals. And today, if she had come in this time, maybe you can use joint as trio and maybe you can postpone the surgery. So I used to give injections of Hyalgan GF20. The VAS score improved, and this I could repeat because according to me, the effect used to last for 1 year, and she went on taking every year for 3 years and 5 years in the left knee. But TKR was postponed for 4 years in the right knee and 6 years in the left knee. And this is the X-ray of 2006 of both the knees,
Very good,
and
very good.
she is very very happy. There is another two cases. I'll put them together so that you get the gist of it. uh, you know this patient well. Mushtaq is our good friend. Her mother,
Yeah.
77 years old, and she didn't want total knee replacement. Left knee I had done with a constrained knee, but then there was wedding of her grandson, and she said no, I don't want surgery. So same way, another gentleman, best friend of my father, had severe OA of both the knees. And the place where I asked for scanogram, I think this must be the situation in smaller towns also. They don't have proper scanogram. So this was the scanogram done over there. So what would you do? Same thing, give injections, visco supplement, buy time by giving some kind of nutraceuticals, and we could postpone the surgery. But then inevitable is inevitable. Only thing is you can postpone it. So I did the total knee, which did not require a constrained knee in both the patients. And the last patient is a very important one to me because he is a watch repairer. He is a achondroplaskic. His height was 49 inches, and he used to travel 40 kilometers from Borivali to Mumbai. These are his X-rays. When I saw him for the first time, that was probably in 2004, and see the gross deformities. So I could buy time by giving injections, the visco supplement every year, and I could postpone the surgery. But inevitable is inevitable. And this is intra-op X-rays in 2008. I did both the knees of his His height increased from 49 inches to 51. His knees became straight. He's become a very confident man. And till this lockdown on 21st of March also, he traveled from Borivali to VT, and this is his result. And these are his scanograms post surgery after 12 years of surgery, and this is his gait pattern. An achondroplasia, but it is needed. When you need the surgery, you need surgery. Of late, we are getting very nice visco supplement injections, and there is a combination of Algan GF20 or hyaluronic acid along with sorbitol, and it is understood that sorbitol helps you in reducing pain and as well as increasing the longevity of the effect. I stop sharing my screen and we can have more discussion and question
Yeah.
answers, sir.
Yeah. So there is one interesting question by Dr. Ashish: how to manage osteoarthritis patients who are deeply depressed? And this is a very important side problem that we see in osteoarthritic patients, especially if they are functionally disabled. Many of them cannot do the activities of daily living, and some of them are obese also. So it's a sort of vicious cycle of obese having problems of the knees, at the same time are depressed because they cannot really do their normal activities. They cannot go out socially. They are sort of obstructed from doing their things. So there are various antidepressive drugs that are there. Since this is little out of our topic today that we are discussing, but antidepressive drugs do help in elevating this depression, and I think we have been using this in the combination of our analgesics, anti-inflammatory, etc. And so there are some of the drugs which are very, very effective in managing the depression. Do you have any opinion, Dr. Dilip?
Yeah, you see, it's a vicious cycle that you have more pain, you are socially kind of boycotted, and then once the depression sets in, and in our country, it's a taboo that if the patient is asked to go to a psychiatrist, not that because my daughter is a psychiatrist, but I would insist in such patients, please do not try to treat yourself. Please seek the opinion of a psychiatrist in a friendly way. That will
Okay.
change the overall treatment. And there used to be one medicine, SAMe, that used to work into those depressed very well, because one of the ingredients was causing wonderful anti depression effect. And I have found if I use SAMe in most of the cases, there is always a little bit of depression element. And when I used to give SAMe, they used to be very all right. Thank you very much for asking this question.
Okay, so Dr. Dharyashil Gaikwad has asked what type of physiotherapy advised to prevent osteoarthritis. Now, again, as I had mentioned in my talk, there are some strengthening exercises which are recommended, especially quadriceps and hamstring strengthening, the calf strengthening exercises, and these are very, very important. So, strengthening exercises, stretching exercises go a long way in helping, not preventing the osteoarthritis, but at least buying time. Uh, so, because one of the aspects of osteoarthritis is sarcopenia or muscles becoming weak, and that is what we have to prevent. We have to strengthen those muscles. Important. There's one question about tranexamic acid to Dr. Dilip, so you can answer that. Whether you use tranexamic acid to reduce
Definitely. Tranexamic
course,
acid,
anti-coagulation.
we had carried out one study also, and it has been very, very useful. Very useful. You can use it pre-operatively, and if your surgery exceeds or you are doing bilateral, you can repeat the dose. It's very, very nice, and it works wonderfully well. So somebody had asked me whether you use tourniquet or not. I don't use tourniquet except for cementing portion, and tranexamic acid has been really helpful to me.
Okay, so there is one question whether this joint test trial can be given in diabetic patient. Dr. Surendra Kumar Sahu has asked. It can definitely be given in diabetes, but it is at the same time it is important that you have to control diabetes. And any of this nutraceutical, I would go a little further, saying that even in diabetic patients or in hypertensive patients, You need to give the basic drugs for controlling diabetes and hypertension, and those very, very important. But you can definitely give this in those diabetic patients too. About how long it can be given in diabetics, I will not be able to answer at this moment. Whether it could be given forever, but at least for 3 to 6 months, it could be definitely given. Any more questions?
Yeah, there was one question by Dr. Gurva Reddy. Did you see that?
No, not Gurva Reddy. That is regarding anticoagulants you use.
Yes. Can you read the question?
Okay, I'm sorry. What antiplatelet or anticoagulant do you use post discharge after TKR?
It's important if your institution where you're working, if you have facility of doing ultrasound pre-operatively, it's worthwhile. And those who are vulnerable cases, they can be picked up. In very bad cases, you must do D-dimer studies also. At least get BTPT, PTT, and INR also is very important, so that you do not get caught unaware. Now, as far as using anticoagulants, actually, current ACCP guidelines recommend the use of low molecular weight heparin, low dose of UFH, UKA, fondaparin, apixaban, dabigatran, and rivaroxaban, which was banned in other countries, especially European countries. But in my last webinar with Dr. Amal Prasad of Kanpur, he has been using it. So I sent him this detail that it has been banned, but still he has been using. So those who have been using without knowing it can use it. In milder cases, even aspirin works very well. And all grades 1B or IPCD grade 1C for at least 10 to 14 days and may be needed till 35 days. If they are grade 1 or so, you can use tweeters, which are a kind of compressive stockinets, and because they used to tweet, so they are known as tweeters, can be a good mechanical way of preventing. But if you have done good surgery and the patient is mobilized and ambulatory from next day, I think the requirement for anticoagulants go down. But we are living in a country, we are living in a situation, not only country, where we can be sued for anything. So rather be safe than be sorry. It's worthwhile using anticoagulants, because if you get one patient also who has this problem of ARDS and pulmonary embolism, I think you will cry and you will not be able to operate. So why take that kind of situation? I would be of the opinion we can debate for hours together, days together, whether to use anticoagulant or not. But if you want to keep yourself safe, my suggestion is use anticoagulants to the rationale where you feel how vulnerable is the patient. I hope that answers that question. If there is further, you can ask on that site where you want to do it.
So there is one question by Dr. Iyer, which is very relevant and very important, because we have lots of population, especially in osteoarthritis, and there are some certain communities who are strictly vegetarian, and we want to know whether vegetarians can use this product, the joint test trio. Unfortunately, it has a red dot, and we cannot really recommend those for vegetarian. In future, maybe we can come out with some kind of variant which would benefit the vegetarian people. Okay, so what is the post TKR protocol for regarding weight bearing and rehab?
No, that question is addressed to you, so you need to answer, Dr. Ram Prabhu.
No, doesn't matter. You can
Doesn't
answer.
matter. Okay.
You are talking about TKR, so you can also talk.
Cemented TKRs, which have been very well fixed. I think you can start with weight bearing in the same evening, partial weight bearing. My method of showing how much weight they should bear is by using a walker, and the operated limb has to go on the weighing scale and should show up to 20 kilos. So they realize how much is 20 kilos of weight, and then gradually go according to the pain factor. They should not put so much weight that they get pain. That should be fine. But for bilateral, you will have to wait and watch for 48 hours, strengthen the quadriceps, because the moment patient starts weight bearing for unilateral, which you have done, and gets 90-degree flexion, they are in very good position to achieve almost full range of movement, and the muscles will become stronger unless you make them bear weight. So weight bearing is equally important, but it should be to the level of tolerance of pain. But there
So,
is no harm. You can start from same day or maybe wait for 48 hours.
so what is your protocol for rehabilitation post TKR?
Post TKR, if it's unilateral, as I said, ambulate in the evening or whenever you have done, at least after 6 hours, make the patient sit up. Then flexion extension, take out the long knee brace. If they are comfortable, then and then only you make them stand with a walker. Or next day when they are much better, then you can make them, when every time when you make them walk, make sure that you give the long knee brace so that the weakness of the quadriceps is compensated. And then by third day or fifth day, patient is discharged. When it comes to bilateral, then it's a difficult situation. They may not be able to stand well, but as I said, the criteria is little youngish patient, so they are good for rehab. So the moment they can bear weight to almost 50%, you can start doing it. And for unilateral, I'll come back to climbing the stairs and going down the stairs. You can start from 6-7 day at home, or the physiotherapist can go home. But one important thing is, do not leave any flexion deformity. Flexion deformity is acceptable only in rheumatoids, and in rheumatoids, never give full extension. This flexion deformity will come in the way of getting good range of movement. So you get rid of flexion deformity. Quadriceps strengthening exercises are absolutely vital. And if it is unilateral, then unoperated leg goes up first. I'll repeat, unoperated leg goes on the stair first by holding the railings always, and operated leg will go on the same rung of the ladder later on. Again, unoperated leg goes up first, then down. If you have a program of rehab of all your TKRs together, then they get encouraged also very well. And for going down the stairs, is operated leg goes down first and unoperated leg follows that. Is it very clear?
Okay. There is one question by Dr. Gayakwad to you, Dr. Dilip.
Yes, sir.
Any role of injection Hylase in grade 4 chondromalacia patella? Do you give, first of all, Hylase to such patients which has only unicompartmental or patellofemoral problems?
Is there any role of injection? Hylase.
Yeah.
Hylase, I'm trying to just decipher. Is it hyaluronic acid or Hyalgan GF20? I'll answer on that, okay?
Okay, fine. You can answer.
Grade 4 chondromalacia patella. And what is patella DG? I can't understand. Okay, maybe it's his name. So you may try, because it works. As I showed, all the three cases, which 4 cases of severe osteoarthritis which needed, they all had even patellofemoral joint involved. So if it's purely patellofemoral arthritis, I want to give a little clue that normally I give injection in the most affected compartment. It's an arthroscopy portal. Generally, I find it's on the medial compartment. So knee is flexed to 90 degrees and then it is given intra-auricularly. But when it comes to patellofemoral arthritis, you just go retropatellar in full extension of the knee. Make sure that patella is mobile. Insert your needle behind the patella and inject over there. I mean, it doesn't mean that when you give injection in particular way, it is going to be there forever. It actually disseminates in the whole joint. But then there is a good way of treating a particular area more efficiently rather than giving indiscriminately.
Okay, Dr. Dilip, what is your choice for post-operative analgesia?
Your voice is not audible. Jara loud karo.
What is your choice of post-operative analgesia? Which drugs and how do you give?
Post-operative analgesia, I'll start from the on the table. On the table, there are many cocktails, and the cocktails were made very popular by our father of joint replacement arthroplasty teacher, Dr. Ranawat, a great man, and he has devised various kind of cocktails. But you can use kind of local anesthetic in the regional areas which you feel are going to be most painful. So that point is over intraoperatively. Post-operatively, the moment patient surgery is over, generally patients are given analgesics in the form of either diclofenac sodium or in severe pain, which you expect later on in little elderly patients, then with what we call as injectable form of ultraset, because if the pain factor is there, their movements cannot be nice. In our institution, we have indwelling epidural, and Baxter's pump is attached over there. That pump automatically injects, or after 6 hours, the anesthetists come and inject their cocktail into the epidural catheter, which is indwelling for 48 hours. This is how you get excellent range of movement, good analgesia post-operatively. So if you have the facility of epidural, I think it is the best way. Otherwise, in USA, I have seen they use morphine pump, and it is according to demand and supply. And if the patient keeps on pressing, then there is a limitation. It will not keep injecting. But then this used to cause lot of disaster like severe constipation, and there are some people who become morphine addict. So we are quite nice in our country where we are using epidural anesthesia along with that epidural catheter, and then we can give analgesia.
Do you prefer any patches, dermal patches?
Dermal patches have limitation in osteoarthritis. In conservative treatment,
No,
they work very good.
post-operative. Post-operative.
I'm saying I will
Yeah.
come to that.
Sorry.
They are not that efficacious in cases of post-operative pain. We have tried with a new patch, which used to be nice initially. I had suggested to even my ophthalmic surgeons, but then later on, I think they found that efficacy is not so good. So when you have post-operative patient who has indwelling intravenous with you can give intravenous to give instantaneous relief. But if you have the facility of giving epidural, I think it is the best. If you don't have, then you can give injectable either IV or IM.
Okay. There's one. Dr. Gopal Mishra has asked, is there any role of empirically vitamin D, B12, and calcium in OA? It is important that we give this adjuvant therapy in most of these patients, especially elderly patients, because vitamin D has been found to be excellent immunomodulator. It is also important that vitamin D in sufficient quantity is given to patients in all the ages, especially so in ladies who have a tendency to have osteoporosis or osteopenia. Similarly, vitamin B12, not in excess, but in moderate quantity, so that their are maintained well. It is extremely important, whether it is osteoarthritis or in normal person. There is one interesting question. Can you help arthritis medicine treatment for COVID-19 patients? So Dr. Samir Afsar has asked this. Unfortunately, we really do not know the pathophysiology of COVID-19 patients, so we do not know whether there is a problem with any medication which are given for arthritis. But in case if there is some patient who is COVID positive, and the arthritis will definitely get a second preference of management because it can wait, the treatment can wait. Meanwhile, you can always do physiotherapy, exercises, etc., and manage them by some kind of analgesics and anti-inflammatory drug. But we really don't know. It might probably come out maybe in 3 months to 6 months. What are the drugs which may be possible to be given in COVID-19 positive patients? There is a question that is there a role of aspirin to activity in post TKR? Dr. Gaikwad has said, and definitely yes, but Dr. Dilip will probably give in detail.
I had told you in grade 1, you can use aspirin.
Yeah.
But initially for 48 hours, you may use oral kind of anticoagulants and then switch over to aspirin.
There is one question by Dr. Dilip again. A diabetic person with vasculopathy can undergo joint replacement therapy if needed, and what will be the results?
What is this vasculopathy is to be understood well, but then Earlier, we used to have the criteria when the digital X-rays were not there, and where you could see the blood vessels were, especially those popliteal vessels. Then we do not encourage the patient to undergo joint replacement. But with today digital X-rays, practically everybody's blood vessels are seen on the X-ray. So that is not the criteria. One, but then if there is a vasculopathy, you need to get arteriograms done, which may be a non-invasive way. And if they are too bad, get it properly treated by the vascular specialist, and then only go ahead. And then be very careful, because generally you will never damage the blood vessels, but then in a vasculopathy patient, if you do it, it's a disaster. So then maintain your flexion beyond 90 degrees when you are doing your cuts.
I think today, Dr. Dilip, there are too many people, the delegates who have attended this webinar seem to be expert in joint replacement therapy, and they would like to use their knife to manage this osteoarthritis more than the medicines. So that's the reason why we have barrage of questions which are related to total knee and joint replacement. Also, I mean, condylar replacement and other surgical management. And these questions, the amount of questions that we have got are what are the risk factors OA in young patients, Dr. Dilip?
No, but first I want to tell you that you explained the conservative aspect so well that they don't have too many questions about it. So
No,
that is
not
your
that.
expertise.
No. I think people would like to operate more because they are orthopedic surgeons. They are staying at home for last 2 months, and
The each to operate.
they're
No, I
yeah.
have
So
given very clear indications. You don't go by X-rays alone, because X-rays may be disastrous, and look at the function and look at the requirement. What is the patient doing? What is the lifestyle? Is the patient just going from bed to the toilet and to the dining table? It is because of osteoarthritis or general debility. In
so
general debility, for example, our own Prime Minister Vajpayee was operated, and then he could never walk well because he had neurological problems. So first solve the neurological problem. Look at
So
that. Don't
look at patient as a whole.
as a whole,
Don't
yeah,
look at knee only, because
and be very
there are
rational.
lots of patients who are there have combined problem with their spine, maybe lumbar canal stenosis or sciatica. There is a referred pain to knee, and many of them unfortunately get operated for the knee, and they do
And
not.
still they are never all right. Okay, so that's one
So
point. Secondly, assess them well, get the opinion of psychiatrists. As I told you, that they may be under depression, and if they have some pain, they feel extra pain. Do not hesitate to do that. And thirdly, you can take your physiotherapist help also. Try to give physiotherapy, and if they improve, fine, and let them beg for surgery.
yeah,
Please
exactly. So
beg
so
for
that
surgery. Okay,
that's
that
why
should be the criteria.
we had a question that do you think that there is a need to relook at managing medically than look at the knife more often? So that is precisely what we want to give a message to all of you.
Perfect,
That
perfect.
of course all of us are operative orthopedic surgeons, but sometimes we need to be orthopedic physicians too, especially when we are managing osteoarthritis of the knee, and we have to be very vigilant, and we have to be very diligent in managing this, and do not use the knife often, but first try out all your options before you actually turn to your knife. And there is, since this webinar has been internationally attended, I am quite happy that there have been questions coming from all across the globe.
No, it is from
From
Nigeria also.
Nepal.
Just have a look
And
from
yeah, and
Lagos.
so we have got one question from Lagos, Nigeria, by Dr. Alwen, who said, "Can we prescribe glucosamine, means glucosamine in diabetic patient, and how long we can prescribe?" As one of the sales informed me, we can prescribe it safe during my OPD days. I remember, but I don't remember the name of representative prescription of representative wearing turban on head with fair skin due to lockdown made again. Joint test till what age we can prescribe and what stage? Till what age can we prescribe and how long? I will be highly thankful if we can get the reference evidence of proof. So again, this actually has been answered before, but I wouldn't mind answering, because all these drugs which have been studied for as long as 1 year, and they have been proved to be quite safe without much side effect, excepting for the gastrointestinal disturbance in some cases. But they haven't had any adverse drug reactions as far as hepatic and renal malfunctions do. At the same time, we have been using glucosamine in diabetic patient also, I have told, but at the same time, it is imperative that diabetic patient needs to have his control of diabetes, and that is given, that is very, very important. But we can surely give that in diabetic patients. Dr. Dilip, you want to add something?
No. His question was really, he might be Fox because it is known as glucosamine. There is no glucose in it.
Yeah, maybe, yes. So
Okay.
glucosamine
And
does
there are
not.
many references. You can just Google by putting glucosamine chondroitin sulfate, and it was like a wonder drug for our Indians because most of Indians who had their children abroad, especially in USA, it was an OTC product, and as a magic drug, they used to send to their parents, and they were very happy. And Rejoint was first drug which was launched, and I distinctly remember it was the first web launch, like we are having the webinar today.
Yeah. So now, what are the risk factors for OA in young patients? Do we have any specific risk factors, Dr. Dilip?
Yes, because it's a vicious cycle, because you can't walk
Operate these
well,
patients.
you can't walk well, and then they can't walk well, so they will put on more weight and weight. So
No.
first thing is,
Possibly this question is regarding the surgical aspect. I feel so. So whether there are risk factors for surgery in
oh yeah,
osteoarthritis.
obesity, BMI beyond 35, please don't operate. BMI 35 is the cutout. I'm sorry, I didn't understand the question.
Yeah. Okay. Fine.
BMI
So
35 is the cutout. Send to your fellow colleagues. Can you believe one thing? I had patients, especially from one particular community, who had kind of no satiety center, and they were 130 kilos, 140 kilos. And I used to refer to my fellow colleague who used to do gastric stapling and other things. They became of 70, 80 kilos, and their arthritis was gone. Who were the right candidates for getting operated, but because of their high BMI, I referred to this special surgeons. And till today, almost 10, 15 years, none of them has come back to me for their joint problems.
So
So it is very, very.
that is a great lesson for all of you to remember, that even 5 to 10 kilo reduction in weight can elevate the pain tremendously. The patient can be comfortable. And in case somebody who is above 100 kilo and if we can really lose 20 kilos, as Dr. Dilip said, and as all of us know, that all these symptoms can disappear like a magic, and they will be very happy, maybe because of the loss of weight, but they will give you credit for maybe treating them with some nutraceuticals. So remember, friends, that there are lots of factors. Though it is a complex problem of osteoarthritis, all these problems can be definitely solved with definite good management of conservative. And if at all, in severe cases, we can definitely manage them by some visco supplements. We can also do unilateral or total knee replacement. And there are various different aspects of managing osteoarthritis, especially of the knee, that we have. We had a great interaction. We have had host of questions, not only from India, but also from Nepal and other places. We have got from Nigeria. And I really thank all of you who have spent this afternoon, evening. And it is a learning experience for us also. When we are talking about osteoarthritis, we also did some of the research we could help. We are also happy that we have got so-called wonder drug today, a joint test trio, which has been bought by as organic, and I think it is going to be drug of future, which would be combination of all these ingredients, which will help in a lot of patients, even with having comorbid problems. So thank you very much, Mayor Organics and Science Integra, to get this TOO webinar online, and both Dr. Dilip and myself are extremely happy that we were part of this. So thank you all the delegates for attending this webinar, and we'll be meeting you oftener. Dr. Dilip.
Oh, my dear friend, we have been together for years, as people would say, donkey's years, since 1970. And this was a good platform to be together. Although we are far, but we are close. That's regarding two of us. But I want to tell you that I must thank the whole team of Mayor Organics who have organized for this webinar, and they chose me to speak. It was really a very, very delightful experience. If at all there were some flaws in my voice at that time, there must be some problem of Wi-Fi because I've been using highest possible Wi-Fi. But I'm extremely sorry if this has happened, and I have been trying to do the best. And I'm really obliged whenever we have your support. I gather that 2,556 people have joined this meeting, which is a very, very great encouragement for us. I thank you very much for being with us, and especially those who have coordinated this meeting also was fantastic, and it was a great honor by the great team which has organized for this webinar. Thank you very much, all of you. And with folded hands, can we take leave from this meeting? I thank you all for being present, and thank you very much, one and all, from Mayor and the audience.
God bless you. Stay safe, stay at home. There are no take home messages in this because all of you are at home. So you can take all these messages with you. All the best.